All right, welcome everyone. Thank you for joining us. I'm Jeanette Brown, Director of Public Affairs at SCAMP. Before we get started, I just wanted to make a quick announcement. If you're not aware, the state's COVID-19 rent relief program launched this week. So if you work with residents who are in need of support, make sure to visit housingiskey.com. SCAMP will be communicating more about this rent relief program over the coming months, but wanted to make sure you knew that the portal is now open, applications are being accepted. And with that, I'm going to have Olivia start sharing the slides presentation. All right, so our program today is how housers can play a central role in resident health and wellness, and we're looking at housing-based care management. Next slide. Our moderator today is Ayako Utsumi. She's the founder of Valon Consulting and helped put together this whole program. So thank you, Ayako, for your help. And we have a great panel today. Next slide. So we have Nancy Rocket Eldridge, who is the CEO of National Well Home Network, Chiara Carvelli, who's Director of Resident Services at Menorah Housing Foundation, Megan Rose, who's General Counsel and Director of Social Impact Initiatives and Housing Policy at Leading Age California, and Laura Trejo, who's General Manager of the Department of Aging for the City of Los Angeles. So I'm going to turn it over to Ayako, who will go over today's agenda.
Thank you, Jeanette and Olivia and SCAMP. It is my pleasure to moderate this panel on housing-based care management. This is the third event and the second for SCAMP that I have led on this topic, and the conversation becomes more robust each time. I want to invite everyone to attend a continuation of this topic hosted by the UCLA Ziman Center for Real Estate upcoming on May 12th, and more on that later. I will start Module 1 with an overview of housing-based care coordination, followed by Module 2, Chiara Carvelli of Menorah Housing Foundation on what care coordination challenges she has and what programs she uses, care coordination programs, followed by Module 3 by Laura Trejo of the City of Los Angeles, Shifting LA to an Age-Friendly City, followed by a case study by Nancy Rocket Eldridge on California Integrated Care at Home and other programs. Module 4, Megan Rose will give us an overview of the Master Plan on Aging and also why Leading Age is supporting California Integrated Care at Home. And all these acronyms will be defined later. We'll end with, each module will be followed, or each panelist will be followed by 1 or 2 quick questions for clarification, and we'll have a longer Q&A at the end. So if you would like to type in your questions in the Q&A chat box, I will be looking at that for each panelist. And if I don't get to it, please retype your question at the end of the Q&A, and then all the questions will be clustered together. So let's begin. So, overview of housing-based and senior care coordination. This also will apply to vulnerable adults. We want to make it clear that this is beyond permanent supportive housing. Next slide. So, I want to thank Laura Trejo for this slide, compliments of Kate Wilbur. So, this is a lot to manage. All these health and wellness services are beyond what permanent supportive housing traditionally provides. How does a vulnerable adult with perhaps a lifetime of inequity manage these 28+ sources of care to maximize benefit and age safely at home? Believe it or not, we are required by federal law to offer community care first before institutional care. Each of these services has its own qualifications, case manager data, communication systems, plus patient confidentiality prevents us from sharing information. Moreover, long-term care and these services are not paid for by Medicare, and Medi-Cal, the health insurance for low income, only pays for a portion. Next slide. So, to complicate matters, residents often go in and out of qualifying for these services themselves are in flux and residents are still vulnerable. The expertise of case managing is highly local to the home. This map looks different in each locality. To further complicate care, constant change may make our residents distrustful. There are numerous initiatives to coordinate care. They're in varying stages of development. These acronyms are defined in the appendix. Care coordination does work, but may be too dependent on star performers rather than a managed system of care. So could we improve health and lower costs if there is local housing-based care management to complement the coordination programs that are working? But why should housers care? After all, we're only the little red circle at the top. Well, it is the right thing to do. And when you think about it, when this map goes awry, the first people on the scene are often property management staff. Next slide. The lack of care management and poor health of our residents does negatively impact housers' financial and operational bottom lines. Falls, suicide, unattended stoves, poor mental health, poor resident relations, substance abuse, maintenance staff time to deal with high-risk residents. All of this results in lawsuits, damaged units, unit turns, uncollected rents, and staff time. If housers ignore health, it will be to our peril. Next slide. I'd like to take this time to stress the importance of health and home. The connection between health and the dwelling of the population is the most important one that exists. Florence Nightingale got it right so many years ago. Home is where most health and disease are generated. Housers are in the best position to gain trust, so important in care. Therefore, housers must play a central role in wellness and disease prevention, but we are not set up to do so. Can we envision how we could adapt? But we cannot do it alone. Let's discuss. Next slide. Chiara Carvelli, Director of Resident Services at Menorah Housing Foundation. Welcome, and tell us about your pain points with care coordination and give us some examples.
Thank you for that nice context, Ayako. Appreciate that, and happy to be here. I think you said it really clearly when we talk about the intersection of health and housing. I run a great team of service coordinators. We are located on site with all of our residents, and that list, that gray list of like the pot on the stove and, you know, poor mental health and poor resident relationships. These are things that we deal with all the time. So they're definitely something that needs to be attended to on site. The areas that we really need the extra support in are though at that intersection of health and housing specifically. And one of the things that I kind of want to highlight is the hospital discharge. I'm just going to kind of throw this scenario out at everybody because I think whether you are like a case manager, a service coordinator, a maintenance person, a manager who's working a little bit late on a Friday. So you have the situation where a tenant gets discharged from the hospital. Inevitably, it's like 4:20 on a Friday, you know, a conveniently inconvenient time for most of us, right? And the resident comes home and things are not in place. Things are not in place for this resident. If that person has been fortunate enough to have in-home supportive services because they income qualify, which is caregiving in the home with like essential things like housekeeping, laundry, food preparation. If they're lucky enough to have that, that provider has not been there because they don't get paid while that person's in the hospital. So the person gets discharged, and even if they had something in place, maybe their apartment's not okay. There could be trip hazards, no fresh food, dirty sheets. Come home, apartment's not okay. And what if they're physically much more impaired than how they left? That happens all the time, we see with like a decompensation after a hospital visit, right? And so perhaps they're not able to get out of their bed to even use the restroom, or any number of things that can happen. So what's happening? It's like 4:20. By 4:25, they're on the phone to the service coordinator. I need help. I don't have any food. I don't really feel that well. Like, I don't know what's happening. Is somebody coming to help me? And so this then falls on the service coordinator. Oh my gosh, there's a lot of questions here, numerous questions. Did they get home health? What's the company? Did they have to choose it themselves? How do they do that? What services are going to be provided? Is it occupational therapy? Is it nursing services? What's happening? Meanwhile, we're trying to get that in-home services provider back just to get the basic things done. Can they come that night maybe? All of this is happening after the person's home from the hospital, in the apartment, just there by themselves. And we're not, with no, most of the time, no family support. So this is something that happens all the time. And while the service coordinator is hustling to figure this all out and calling different doctor's offices, multiple extensions at the same places, maybe they got discharged from a rehab. Can they get the social worker on the phone? Perhaps they've been trying to call prior to the discharge, but nobody's returned a call. HIPAA doesn't let them share all the information that's really necessary. So all these things are happening. And during the time that we're trying to put these many, many puzzle pieces together, the person falls. They fall again. Why? There's not a nightlight. Nobody's been there to assess their apartment. There's no nightlight and they need to get up in the middle of the night. Why did they fall? Oh, there was a dirty sock in the hallway because the provider hasn't been there to tidy up and they can't bend down to clean that stuff. There's so many reasons for falls. So this area is an area we struggle with. And it's like an ad hoc situation each and every time because there is no cohesive, reliable, expected system to put these pieces into place. When you have a great team of service coordinators, like fortunately, like I do, we have moderately successful results, but it takes a lot of work and there's a lot of suffering. And sometimes we don't get anywhere. And it could be a few days before anyone's even coming to see this poor person. How many times have we used petty cash to make sure they got some peanut butter and a loaf of bread just to get them through the weekend, until we can get someone back. So this is one area that we see a big weakness in. And relatedly, even when people are not just discharged from like an acute hospital setting or a rehab, I think Ayako was also mentioning like the kind of people who slide in and out of programs a lot. Maybe they're formerly chronically homeless. Maybe they're just beginning to get dementia, can't lose their paperwork a lot. Maybe they're just disorganized or just have a lot of chronic health conditions complicated by mental health that are going on. And these people just require lots of different disparate health services that the service coordinator, as our title, right, we're coordinating all these things. But when it's specifically in regards to like health, doctor's offices, physical therapy, rehab, those kinds of services, we run into major roadblocks with the lack of a system, and the hesitance sometimes to share information with us. Not to mention the obvious barrier of things not being field capable, right? Sometimes people want you to go back into an office, back somewhere. And a lot of our people are just needing to be home, unwilling to get out into the field, unable. This whole area could use a lot of ironing out instead of, I think Ayako said, like a star player having to just create it each and every time. So that whole situation is problematic and something that we are constantly trying to reinvent. What is working along those same lines, though, of care coordination is something called the Assisted Living Waiver Program. And I'm going to give it just a very, we call it the ALWP. And it's a Medi-Cal waiver that Megan Rose would be able to explain a lot more eloquently than I can, but it's a waiver program that allows people who need a nursing home level of care to remain in a lower level of housing. So often it's used for people who would theoretically need to be in a skilled nursing situation, but they reside in a board and care and can get that kind of care in a board and care instead. So they don't have to be institutionalized. In our setting, there's only a couple incarnations of this, I believe, in California, where we have the assisted living waiver program on site. So we have an existing building, which is just, a regular independent subsidized housing for older adults. But there's, in addition to the manager office and the service coordinator office, there's also an office for the home healthcare agency. And for eligible tenants, they are allowed to sign up for this program and get all kinds of extra help in their home, primarily medication management, blood pressure checking, nursing services. The key thing about this program, you don't have to give anything up. You don't have to change your doctor. You don't have to give up your IHSS. It's just in addition to what they have. They are also enrolled in the assisted living waiver program, and it works. It works so well. People can stay in their apartments for, instead of having to go out to a higher level of care sort of unnecessarily. Really the only issue with it is that the state's not prioritizing this as much right now. And so we can't replicate it in the same way, but we do love the level of care coordination that it offers. Similarly, the PACE program, which is Program of All-Inclusive Care for the Elderly, they're becoming more prevalent in the LA area. We love that program. It's basically an all-in-one for the tenant to receive their health care. It's not really field capable. People do go, to the centers to receive their care, but transportation is provided and it works very well. The issue with this program is that there are major barriers to enrollment. They have to give up their in-home services provider, which is sometimes a family member. And so there's a money trail that happens with that. Oftentimes they need to give up their doctor because the doctor's not contracted with PACE. So again, coordinated care systems work, but they have their impediments. And so we're looking for things to really help tie in the gaps to the health and housing scene, layout, structure. So those are things that we really see as being in our area of something that we would like to continue to cultivate new ideas.
Thank you, Kiara. That is so helpful for helping us to see what does it really look like on the ground. Thank you for that. And I saw one question in the Q&A as, can you get the slides? And the answer is yes. We'll make sure that happens at the end. Thank you, Kiara, making it real for us. Next slide. Let's move on to Laura Trejo, General Manager of the City Department of Aging. Laura, welcome. How can we shift Los Angeles to an age-friendly city? Can you please start by describing the senior population in Los Angeles? A brief overview. How many do we have? What does it look like in the next?
Sure. And I'll do it for the region because I think that's will encompass most of our participants. The Los Angeles region has one of the largest concentrations of older people in the United States. We currently have about 1.8 million older adults over the age of 60. And we are expecting that over the next 8 years, we're going to see almost 2 million just in those 65 plus. Our fastest growing segment of the older adult population in the region are people over the age of 85, which for all of us who work with older adults means those are the folks that are more likely to experience some kind of frailty. The work of Los Angeles is also very unique. We have two federally designated area agencies on aging. One at the city, my Department of Aging, and the other one is at the county with the Workforce Aging and Community Services Department over at the county. We work very much hand in glove to try to respond to the regional needs of older adults in our community. In fact, in 2016, we launched Purposeful Aging Los Angeles. We became part of a worldwide movement of the World Health Organization looking at developing age-friendly communities and cities. We're part of over 100 million older people across the world that are sort of working in this environment. looking at local communities and really digging in about what it would take, what elements would be necessary for our communities to be aid-friendly and to really be places that it will age well. Our motto is we're going to make the Los Angeles region the most age-friendly in the world. We want it to work for all ages, but we want it especially to work for older people as they're aging in place. Just to give you a sort of a perspective and a reference, only 10 states in the United States have more older people than Los Angeles County. It's one of the most diverse populations when you look at racial, ethnic diversity. Linguistic diversity is also extremely rich in our community. So that is one of the assets that Los Angeles has, is we have this incredible diversity of our community, but that's also a challenge for service providers. Because, you know, when I think of issuing a flyer, for example, I have to think about 12 languages being available. It's very rare that we can do something in just 1 or 2 languages. So, like, for example, all of us are experiencing the pandemic. The pandemic has special implications for communities of color and for making sure that we are reaching out to the communities in the languages that they understand what's going on around them. So that's been an exercise. We were very, very blessed that we had started this work of becoming a age-friendly city before the pandemic, because we used the platform and infrastructure we had been building among, over 40 city departments and over, 37, I think, county departments together to mobilize the region, so that we've been using all of those connections, over 300 stakeholders that we're working with, to move us through this last year. I don't think we would have been as successful in sort of generating the level of work that we were required to do in our community without being able to use the incredible supportive structure that we had built. But you also had asked me to discuss the issues related to care management in our system. Area agencies, by definition, offer care coordination, care assessment for independent living seniors in the community. But as I was, thinking about it, our systems are woefully inadequate to meet the needs of this growing population. We have not been funded appropriately, like most systems and social services have not. And so there's a real disparate availability of resources. In some organizations, the staff is highly trained and highly educated in terms of models of care for older people. In other communities or other agencies, that is not a priority. So those communities may not have the level of service being equitable. So a lot of the work that we do with the department is try to figure out, how do we enhance the resource availability in communities through training, through facilitation, through creating partnerships among organizations. Part of the work that we're doing, and I'm going to put it on the chat, is that we actually have an action plan for Los Angeles. And one of the 8 domains that we're working on is housing. And so there is a great opportunity for this audience in the Los Angeles region to be an active part of helping us to define the types of models, the types of interventions, the types of things we want to see in our communities. And for those, if you are not from the Los Angeles region, I want you to know the governor last year actually signed into law a bill bringing all of California as an age-friendly state. So there's an opportunity everywhere. Every community can participate. In Los Angeles, we now have, I think, 8 or 9 of the local cities that have also joined the age-friendly cities movement. So this is something you as advocates can actually influence at the local level wherever you're living. I can tell you, before COVID, I was on a mission to encourage all mayors in the other 87 cities in Los Angeles County to join our coalition, because I think it's so important that we have a shared vision of what we want to do with older adults. But when we're looking at social supports and social services, I think there's still a lot of work of innovation that can be done, a lot of models that need to be developed, a lot of partnerships that are probably fledgling infancy stage, developmental stages, that really could become very rich sources of support for the client populations that are living in congregate housing, but also the ones that are living in the community. So my hope in the work that we're doing with age-friendly cities is to really look, and I can tell you, we are looking worldwide for models that are being used everywhere because people are innovating all over the world. And we're saying, you know what? We could always try it here. It may not work, but at least we have an idea of what people are trying with their aging population. So I want to really encourage everybody that is with us today to really join us, to go to the Purposeful Aging LA website and sign up and be part of our network to try to create the change that we want to see in this community. It's going to take all of us working together in order for these things to happen. And so I really want to encourage this audience to embrace this great opportunity. We currently, and we're going to be discussing it in a minute, we have a master plan on aging. We've never had that before. We have an action plan for LA County. We've never had that before. So we have a lot of moving pieces in our local community that we need to start embracing as a network that really affects how we care for older adults wherever they're located. But in particular, those in housing that need a higher level of resource. That's one of the areas we think about all the time, older adults that may be living alone. And so that is something that I think is a critical first step. This is, I think, a foundational activity, is us coming together, starting to share, starting to know the network so that we know who the potential partners are moving forward and working together. So I appreciate the opportunity of being with you this morning. I look forward to having everybody reach out to us. And like I said, in a minute, I'm going to post on the chat the Purposeful Aging LA website, so all of you can download the report, review it, and reach out so we can start working together and making our community better. Thank you.
Thank you, Laura. That was so helpful. And I see a question in the chat. Laura, is the LA Age-Friendly Communities working with AARP California?
Absolutely, we are. Actually, AARP on a national level is the organization that is moving this agenda forward. In Los Angeles, we're very lucky that we have AARP for California here in LA. So they are part of our steering committee. They have been a foundational partner of all of our work. We're very grateful to them.
Thank you, Laura. Fabulous, fantastic information. So let's move on to the case study. Nancy Rocket Eldridge of National Well Home Network. She will introduce the California Integrated Care at Home, and there's a whole bunch of acronyms that she will get to. Nancy, tell us about SITCH and how it can answer some of the questions that have been brought forward today. Nancy.
Great, thanks, Ayako. Could we move to the next slide? And the next one, thanks. Great, so I wanted to begin by just reassuring you that there is a great deal of experience and evidence base behind the kind of population health system that California Integrated Care at Home will be. And it begins with, it begins with about 10 years ago in Vermont, we realized that the healthcare system simply wasn't working for a lot of people. And, you could hear Kiera say that. I loved it when she said, every situation was an ad hoc situation, and her great staff dealt with it very well. But we felt as housers that we needed to be part of the solution, because it was our residents, older adults and younger people with disabilities, that were really suffering from a lack of system. So we started our systems change in 2011. And then in 2014, our Senator Leahy, who's now President Pro Tem of the US Senate, submitted an appropriation for HUD so that it could do something like SASH. And so HUD created the Integrated Wellness in Supportive Housing demonstration, which launched in March of 2018. That has been a real learning experience in terms of what Laura was mentioning in terms of multiple languages within one property and how that's managed in terms of care providers all coming into that setting. So that's led us to California Integrated Care at Home. Next slide. So I just wanted to note that California has more IWISH sites than any state in the country. 3 of them are located right in LA. You can see the 3 sites totaling almost 500 units themselves. They've just done an incredible job in implementing the care management model. So a total of 15 in California, and then there's 6 other states that have 2, 3, 4 sites. But what's really important for us is to make sure that the IWISH sites that have now been working so hard since 2018, that they can be wrapped up into SITCH and continued with sustainable funding. Next slide, please. So when any community realizes that their healthcare system isn't working for the most disadvantaged populations, we ask ourselves, who knows their needs? And of course, we need to go to those individuals where they live. As Ayako said, home is where health and disease is generated. So when we started our systems building, we realized that we had this enormous housing infrastructure in the state. I mean, we had this platform that had thousands of housing units from all sorts of programs, HUD, USDA, low-income housing tax credits, mobile home parks, home mortgage programs, home rehab programs, you know them all, you do them. So we realized we had this huge footprint, this ready-made system to get a population health system to scale. So that was number 1. Number 2 was we have tons of staff. We have custodians, we have maintenance workers, we have property managers, we have service coordinators, all caring people who have the residents at heart. And so we realized if we could harness up the staff at all these thousands of housing sites around the state, we could literally have them aid the healthcare system in a way that really was very in tune with community health worker kind of thinking. So that was a really important and convincing argument to make to the healthcare system. Third, as Laura talked about, there's AAAs, there's mental health agencies, home health agencies, there's so many agencies. And we realized if we could formally connect and have really clear agreements about how can we help each other? We all had caseloads that were just too big to manage and with not enough money to do so. But if we could be clear sort of horizontally how we were going to work together, that would mean that we would have the power that's larger than the sum of all our parts. And next, we realized that we needed to embed care teams right in the housing, not just to serve the residents there, but to serve the entire surrounding neighborhood. Because we had so many, in our state, we've got 140 hubs. And so that creates this hugely decentralized reach into the community where we can reach people who are maybe living in a single family home, in an apartment, in a condo, in a farmhouse. So having that ability to embed the team and train all of them, consistently is really important. And then last, we wanted this system to be funded by those who were benefiting from it, whether it's insurers, whether it's hospitals, whether it's primary care providers. And so our system is now 10 years old, paid for by our all-payer model, which is a Medicare CMS approval. Next, please. So this is just the most recent numbers from the National Housing Preservation Database on California in terms of, this is just rental housing. So you have 436,379 publicly assisted rental units. And then you can see far over to the left why you have a homeless problem. You are missing 998,613 units. That's your shortage just on the rental side. And then of course, when you add all the home ownership programs, you have an enormous platform in California today to build upon. Next, please. So here's the tricky part about this. So you see California Integrated Care at Home in the green box at the bottom. So as housers, think about that as the foundation of a home or a building. It's permanent. You can set a lot of very cool things on top of it. And they have different characteristics to them. So that, you have many incredible programs in California. And as all programs do and should, they have restrictions on them. You have health homes that are Medicaid, Medi-Cal initiatives that have income limits related to Medicaid. You have time limited supports like home health where there's episodes of care. You have programs that require that you have a minimum amount of health need. That whole person care is an example of that, where that is really targeted to people with consistent complex care needs. You have programs that have restrictions on choice, like PACE, which is a fabulous program, and we need much more of PACE. But it does restrict the participant to the particular PACE doctor that's with the program. And then you have programs that have locational limits, like iWish. iWish was only available to HUD housing sites. It wasn't available to tax credit or anything else, or permanent supportive housing, of course, is attached to an address. It's not, everyone can't participate in that. So the key point, if you take anything away from this, is that what you all are building is a system. And if you think of many systems in this country, whether it's education or interstate highways, they're meant to include everyone and serve everyone, even though perhaps in very different ways. So let's move to the next slide. So the care team is one full-time care manager and a half-time wellness nurse. But importantly, family members, neighbors, volunteers, every asset, so all those programs I just mentioned, none of those go away. It's just that they work together better. They knit together better. Family members would say to us, oh, thank God we've got SASH. We don't have to, be visiting mom every day. And would say, well, not every day, but at least every week, or when she goes home from the hospital. I mean, you're part of the team. So that's key. And then, of course, part of the team is all those agencies I mentioned, where we enter into agreements to be clear on who does what, and have put together a very cool training program that is never ending and consistent, and really has given the healthcare industry a lot of faith in housers, because, for example, they didn't think we could comply with HIPAA. And I said, housers, that's what we do. We are compliance experts. That's our particular skill set. And so for 10 years, we have not had one HIPAA violation. Next slide, please. So how are we doing on time, Ayako?
You have 3.5 minutes.
Okay, thanks. So there's a very fixed number of activities and steps that these models, whether it's iWish or SASH, follow. And beginning with a motivational interview, which is really about beginning to empower the person to stop coming in and telling people what they need, but help them determine what they want to have. And that's the key. And then we do, lots of screening, lots of data collection, lots of data sharing with all the providers and hospitals and agencies, which has, been a huge problem, being able to share that electronically. the participant agrees to a health plan that they participate in deciding upon. So important. If somebody, wants to get reduce their hypertension or their diabetes, it's not going to happen unless they decide they want to, and that's that. I think the others you can read. Next slide, please. So as all our communities get older and older, the urgency is growing for us to figure out these systems of care management. So we've got SASH in 3 states, Vermont, Rhode Island, and Minnesota. We're active in Maryland and California. And then there's a whole bunch of states that are lining up behind. AARP National has announced in January that they're advancing the SASH model or models like it, like California Integrated Care at Home. None of them are the same or should be the same because you're a very different community, but there's certain guiding principles that can be pretty consistent. So lots of interest out there, and we really need to get to our federal government to support this interest and address this urgent need. Next slide. So I'm going to end here and just say, if the healthcare system is to work for everybody, everyone needs to have a voice in it. And that's what the supporters of California Integrated Care at Home are all about. Thank you all for being here, and thanks to SCAMF and thanks to Ayako for being our fearless leader.
Really, thank you, Nancy. Do we have any questions for Nancy? Nancy actually is the one who helped develop this concept, and her life mission is to make sure that everybody around the country who is vulnerable can have a wonderful support system like the California Integrated Care at Home. Any questions for Nancy? Okay. Well, thank you for that, Nancy. We are very excited to hear more about Baltimore. It's a city that's up and coming, or Maryland, and we will be keeping close tabs on how Maryland expands their program. And I want to make it clear that this is happening across the country. This is a movement, and can we in California be a part of that? All right, let's move on to Megan Rose. She will give us an overview of the Master Plan for Aging for California. And as Laura said earlier, the first time ever, and the first time ever they mention housing. Ta-da, it's a miracle. And so Megan, tell us about the Master Plan for Aging. Why is Leading Age California supporting it? Megan.
Thank you. So Olivia, if it's okay, I will start sharing my slides. All right, so hi everyone, and I've already seen some names in there, people I know. Hello Donna. My name is Megan Rose. I'm with Leading Age California, and we are a trade association, but unlike some trade associations, we represent a lot of different types of trades. So we represent nonprofits across the aging continuum, nonprofits that provide affordable housing, assisted living, skilled nursing, life plan, communities, PACE, many of these acronyms that you've heard here today. So we have been very involved with the creation of the state's Master Plan for Aging. And I just want to give you a little background of the Master Plan for Aging, because we feel that this is one way that we can help make California Integrated Care at Home a reality for California from an advocacy perspective. So back in June of 2019, the governor issued an executive order calling for the creation of a Master Plan for Aging. The executive order covered a lot of different policy topics. Housing was not one of them. So automatically we were a little concerned, because we know that housing is the #1 issue facing many low and moderate income older adults. So shortly after the release of the executive order, the governor appointed a stakeholder advisory committee, which included our CEO, Jeannie Parker Martin, And the work of the Stakeholder Advisory Committee was to draft a series of recommendations to go to the governor and his cabinet so that they could write the master plan for aging. So after about a year of work that amazingly got done on time despite COVID and all of the setbacks that kind of threw, the Stakeholder Advisory Committee submitted the final recommendations to the governor. And the governor took a few months. He and his cabinet reviewed, I don't remember, it was tons of pages of recommendations, ranging from everything: housing, long-term care, parks, the environment, I mean, you name it, transportation. There were a lot of different things covered. And so the final master plan for aging was released in January. And so within the recommendations that the Stakeholder Advisory Committee had put forth to the governor, our main message was housing is a human right. This has to be included in any master plan for aging. Housing is foundational to our continuum of care for older adults. It's very difficult for older adults to receive proper healthcare, including preventative healthcare, when they don't have a safe place to live. So the main things that we focused on in our recommendations to the governor were that we need better data. We just really don't have a lot of data on the housing needs of older adults. We need to create more affordable housing. All of you know, supply. We just need more affordable housing in California. We need to help older adults who are living in the community, who are successfully housed right now. How do we help them stay housed, whether that's with rental assistance or with home modifications? What do we need to do to make sure that they stay housed and they don't become homeless? And then finally, once we have everyone housed successfully and safely, how do we provide these older adults with the long-term supports and services they need to remain housed and to avoid unnecessary premature placement into like a skilled nursing facility? So the work team that I worked on through the master plan for aging process came up with this nice graphic that I really like, because we really felt that, this shows what we're trying to say, is that housing is the foundation that makes our communities livable. And so through the development of these recommendations for the governor through the master plan for aging process, SITCH, as we call it, California Integrated Care at Home, was born. And I started working with this amazing group of women who have been so inspiring and so intelligent, have such wonderful experience. And we've developed this model. We called it California Integrated Care at Home, and we put it in a 3-phase approach in the housing recommendation. So first, we need to secure a CMMI grant and design for the demonstration. Next, we want to launch a demonstration in Los Angeles County, and we picked Los Angeles because we feel like, as Nancy talked a little bit about this, there's a lot of affordable housing and there are a lot of resources. And we like to say Los Angeles is resource rich and can be coordination poor. And California Integrated Care at Home is the model that can help bridge the gaps and bring all of these wonderful resources together to create kind of this no wrong door entrance for an older adult. So an older adult who is within this SITCH model doesn't have to make 100 phone calls to figure out where there's someone that can help them on any certain thing. So this is the goal. So if we can make this work in Los Angeles, we can make this work anywhere. So that's the midterm goal. The long-term goal is to then use the lessons learned from this demonstration to build out a statewide permanent California Integrated Care at Home program. So in January, when the master plan was released, we were beyond excited that housing was named as the #1 goal, especially considering the housing wasn't even mentioned 2 years earlier in the executive order. So there are 11 initiatives total that fall under housing for all ages and stages. And I kind of pulled a few highlights We at Leading Edge California, we represent developers and operators of affordable senior housing. And so these were some of the initiatives that we were most excited to see included. So one is looking at tax credit and other financing strategies to build more units for extremely low and very low income individuals. And then number 5 is the data piece that we talked about. We just don't have the data. We don't know what the needs are among our older adults. Number 6 is reviewing existing programs like our tax credit program, like the Affordable Housing and Sustainable Communities program or the multifamily housing program, looking at those to see how those programs can better serve older adults. And then finally, number 9, which I have a little star next to, because we really feel like this is where Sitch kind of fits in to this advocacy piece, is exploring opportunities to increase availability of housing options with housing for health strategies. So around the time that the Master Plan for Aging was released, the governor released his January budget proposal, and we kind of knew that there wasn't going to be a lot of funding in there to support the Master Plan for Aging, just because, we're in this recession. The state doesn't really have a lot of money to fund any new programs. So one thing we were really surprised to see was that there was a line item for senior housing, and I put that in quotes, and I'll explain why, at $250 million. So what this is $250 million for one-time general fund funding for the California Department of Social Services to acquire and rehab adult residential facilities and RCFEs, residential care facilities for the elderly. So this is not in the typical, housing parlance. We would not call this senior housing, because this is really talking about board and care facilities, assisted living. These are regulated, licensed facilities, and they are very important to our continuum of care, because this is often where higher acuity individuals who are experiencing homelessness can be placed and receive the care that they need. And there has been a problem with a lot of these businesses kind of going under. There are a lot of issues with state funding. State reimbursement rates are very low. So it's very difficult to keep these buildings operational. And COVID has exacerbated that even more. So this is an idea to help kind of infuse some cash into that market, and hope, with the hope that these businesses can stay operational to help these older adults that need it. But it is not to build what we would call affordable housing.
Megan, I'll ask you to wrap up.
Go ahead.
I'll ask you to wrap up.
Oh, okay. So the other thing that we're pretty excited about was this idea to create an Office of Medicare Innovation and Integration. And that is because in order to make this work, we need a multi-payer model. Because if you look at it, the largest beneficiary of all of this is going to be Medicare, and then you have private insurance. So we really need a way to pay for this that is not going to put the onus all on Medi-Cal. We need Medicare and private insurers to step up and join California and Medi-Cal in paying for this. This is the only way that we can replicate it and scale it to serve all of the needs of California. And with that, I will close out. Thank you.
Thank you, Megan. Thank you for that overview. Master Plan on Aging. Finally, housers, we can interact with the aging services from the state. So I have a few questions in the chat, but before I get to them, I'd like the housers on the call to think about, what do we as housers, given what we've heard today, what do we want to hear from our state government, the policymakers, the people who are allocating resources? What do we as housers want from the Master Plan on Aging, from all the programs that we have out there that coordinate care for the vulnerable? What do we want? What is our voice? And we want to come away from here with some ideas and a charge to action. But before we do that, I will answer a couple questions. Anything specifically for Megan Rose? Any questions specifically for Megan? And then after that, we'll go back to a few questions from earlier. Okay, so I have one question here. It says, are there policy initiatives that we can support federally for housing-based care coordination? Nancy, I'll let you take that.
So great question. We're working with CMS and CMMI, which you all may understand is the Centers for Medicare and Medicaid Services and the Center for Medicare and Medicaid Innovations. And as Megan mentioned, what we really need the federal government to do is to fund demonstrations in California and other states, and to fund prototypes of multi-payer funding pools. And I think, you know, together we should all be looking at opportunities as it appears that earmarks are going to be resurrected, that we look at ways that, you know, powerful senators can work together to make that funding possible.
Okay, thank you, Nancy. And we have another question. This is for Laura. Does the Purposeful Aging LA Initiative, PALA, support initiatives that combine recommendation categories? Such seems perfect for the housing prevention of further homelessness and community support for health service. Scale up, proven, community-based evidence-informed health promotion and disease prevention initiatives to align and implement together. So does PALA support initiatives that combine these categories? Laura.
Absolutely. And also part of the work that PALA has been initiating in Los Angeles also specifically addresses on housed older adults. We actually have been moving the needle very aggressively in that area. So there's a lot of opportunity, and we need all of you to help us develop those new models that Nancy was referring to. Because part of the problem is that there's not a lot of interventions that are specifically for older adults, which is your expertise. And that's what we have to bring to the surface so people understand that you're there. Right now, they don't know that. But thank you. That's a great question.
Thank you for that. And this next question is for Megan. Why is the data low for the aging population? Megan.
Yeah, so good question. You know, we've talked to a lot of different people about this, and it seems that for a long time, there has been information collected around youth, children and families and homelessness, but there's really not been a breakout of data for those who are, you know, 65 and older, 60 and over. So that's something that we're working on. There is a little bit of data coming out of Harvard, just not enough of the localized California data that we really want to see.
Okay, thank you, Megan. And now we have a question. This was for Kiara. She answered in the Q&A, but I'll just read it out. And Kiara, if you could answer briefly. Do you have to write policies and procedures for property management and services to follow when a resident can no longer live independently? It seems like our legal imperatives are unclear in this situation, although we certainly know our mission imperatives. Kiara, do you want to just briefly answer?
Love this question. This is so real. This is 100% what we're all dealing with. So I briefly just said that I'm really fortunate to work with Menorah because we are the property managers, we're the service coordinators, we're the maintenance. We are all on the same team. So collaboration, I think, is a lot easier for us since we're literally just all from the same company, right? So we all have the same mission. And this opens up that whole topic to like transitions to higher care and what can you do? Your hands are tied. As a houser, ultimately your hands are tied. The only trick you have up your sleeve is an eviction. That's all you got, right? And nobody wants to evict. That's not what that's the opposite of our mission. So I actually have like a document that I created a few years ago. That's kind of like a list of steps that we exhaust before we even try to think about that. And they're all based on safety. So safety is the guiding principle, you know, if it's a fire, if it's a dementia thing, if it's a wandering. I mean, the variety of problems is wide. We all know that. So the brief answer to that is the service coordinators work in tandem with the property managers. We do a little bit of good cop, bad cop. Somebody gets a letter because they did, they left their kettle on, and then the service coordinator comes in and is like, hey, I know you got a letter. Can we work on that? Maybe can I call your daughter? Maybe we can collaborate and try to fix these things. So that's kind of how we address it. We have a list of steps that we take.
Thank you, Kiara. Thank you for that. And we are all out of time. This has been such an interesting discussion. I'm going to ask Laura Trejo to give our call to action. Laura.
Well, I just want to thank Ayako and everybody at SCAM for bringing us together. And the call to action to all of us is California is about to start getting a lot of money into our communities as part of the COVID relief, as part of the governor's budget. We need to start contacting local elected officials and making sure they understand that older adults live in their communities and that they have a variety of needs. And many of those needs, you have opportunities to have solutions you can present for their consideration. So I want to encourage all of you to become part of the network, to become part of the people developing the innovation and the new models of care for older adults. Thank you.
Thank you, Laura. And next slide. We want to invite you to continue this discussion. UCLA Ziman Center for Real Estate is continuing this discussion on May 12th from 11:30 to 1. You can see this illustrious panel. Megan Rose will be returning. You can look for more information in the chat. There's a link. We hope you can attend. Again, let's stay connected. Let's continue this discussion. Thank you, everyone. Have a great day.